just a few words about myself. I'm Ole. I'm living here in north of Copenhagen. I've been involved in HIV medicine since '96. I've been involved in clinical work. I'm responsible for an in-ward and doing some outpatient follow-up as well. I've been involved in HIV research on a European level for more than 20 years, dealing with optimizing treatment for people living with HIV. I have a special interest in the situation in Eastern Europe and aiming for assisting people or doctors in that region to optimize treatment and management, obviously based on the experience we have here in Western Europe. And I think that's it. I would just say, coming from a medical background, I may have a slight tendency to dig into details, and if it gets too detailed, just interrupt, say enough or whatever you want to say, just so that we get that out of it that you expect to get out of these 2 hours. I hope that you will interact. That's what I heard from Daria as well, that you are a good and interacting group, and I hope you'll continue that today so that we can have discussion rather than me talking for 2 hours. So please interrupt. I would actually rather that you ask questions in person rather than writing a chat, because I cannot follow the chat from where I'm sitting. I wouldn't like you to go for a parallel internal discussion and I'm not following. So whatever, if you have a question, no questions are stupid, all are relevant, so just ask. I think that's it for now. I have made an agenda going through many of these things, but before starting up, I would actually like to hear, say anything that you are looking for, that you are expecting me to cover in this session, after the session that this Tuesday. Is there anything you would like me to elaborate a little bit on, things Daria mentioned, but you didn't have time to discuss in details? That's a question for you. Okay, but otherwise, just let me know during the next few hours time. So starting up with these, I know you discussed the EATG guidelines this Tuesday. Obviously, there are other international guidelines. The European guidelines are frequently used in Europe, not only Western Europe, but actually also in Eastern Europe. The WHO guidelines, there are many, but this is just an example from last year. That may also be a political document, perhaps in more so than the EATG guidelines. The EATG guidelines are aimed to be a practical tool used in clinical practice, and I think that reflects the difference between the two guidelines. Are any of you familiar with the WHO guidelines?
I'm not.
No. Traveling, I've been visiting colleagues in Eastern Europe and ex-Soviet countries, and they rely to a higher degree on WHO guidelines. But if you look at and if you compare the two guidelines, there are more practical details in the EATG guidelines. Then obviously there are US guidelines as well, and they are very, I wouldn't say sophisticated, but they're very detailed, describing all aspects. So that's the main difference between the EATG guidelines and the US guidelines, I would say. What can you use the guidelines for? You as a group, what is that of benefit for you having these guidelines? Who's first? Just speak up.
I think it's basically the ability to some extent to be able to explain to the potential patient on what is expected or what she or he will face, let's say. But from my point of view, as a volunteer, I wouldn't go much into the details. I think it's a physician's job to explain that in the details. But overall knowledge definitely would help me to explain somehow the next steps.
Yeah. Any other comments? I think sometimes I experience that people use the EATG guidelines as an argument for this is what people would do in Europe in general. So why are we not doing that? And I can see that argument in many places, and I think that's probably where it's helpful as well. That we as clinicians can follow what are people actually recommending on a European level, and how is our practice compared to that. Anything else? So just, I know this is not a good slide, but this is the WHO guidelines where the recommendation is dolutegravir plus a nucleoside background, 3 drugs, and as an alternative, efavirenz, low dosage efavirenz combined with a nucleoside backbone. And then as a third option, having regimens-based regimens as an alternative first line. But just saying, this is not as detailed as the EATG guidelines, as I mentioned before, and there are obviously many reasons for why these guidelines are as they are. Efavirenz regimens, it's very long. It's not a first recommendation in the EATG guidelines. It has, I think you discussed that yesterday, did you? That there are some neuropsychiatric complications which can be associated with efavirenz, and therefore it's not used in most Western European countries any longer, unless people are already on the treatment and tolerate it well. The point is, and I think we can probably discuss that at a point during these hours, the point is efavirenz, it's a generic drug now, so it's very cheap, meaning you can actually treat many people with a regimen based on efavirenz compared to a regimen based on dolutegravir. That's not really a tough issue in most countries in Western Europe, but certainly when you come to countries as Ukraine, Belarus, Russia, the discussion will be different. As far as I heard from the presentation in the beginning, there are 1 or 2 people from Poland, and I saw from the list there should also be a person from Romania. Is that right? Good.
Yeah.
Yeah. So any comments on this? Are you familiar? I already asked whether you are familiar with the WHO guidelines, but I didn't hear from Romania. I'm not sure I heard whether there are any preference on EATG and or WHO. Is that right?
Yes. We have to do this to get of EATG. Yeah.
Relying on EATG. Yeah.
The doctor of Mariana Mardarescu, they reading like this guide of EATG.
Yeah. Good. So just briefly mentioning again, I know you discussed this Tuesday. These are the recommended regimens being dolutegravir based and with a backbone of 2 other drugs, and they are all listed here. So the third drug, an integrase inhibitor, first dolutegravir, bictegravir, raltegravir, they're all mentioned here as recommended regimens. And further down the list are other regimens, namely non-nucleoside reverse transcriptase inhibitors such as doravirine-based regimens or rilpivirine-based regimens. And there are also options for protease inhibitors, and others are listed here. You can see that the efavirenz-based regimen is very near the bottom of the list here. So I don't want to go into details. I believe it gets too technical going through all these regimens. Do you have any questions to any of the regimens? So just what we usually talk about, single tablet regimens or fixed dose combinations. And I think Daria showed this slide Tuesday as well, saying obviously it's often a clear patient preference. It may improve quality of life. It may lead to patient satisfaction. It may be easier to take, and it may reduce prescription errors. Problems here are that some regimens are not available as fixed dose combination. Patients may need to switch to separate tablets in case of intolerance or development of resistance or contraindications developing. And also these fixed dose combinations are more expensive in some countries. Do you have access to these fixed dose combinations?
Yes, in Poland we do.
Poland, what about other countries? Romania?
Yes. Depends of this medication. When I see that, depends on the change of medication, the preference of medication depends on the CD4, because in Romania they not they take a medication of the change medication. It's important of CD4 because almost patients of infection HIV, they have a same to Stockrine, for example, they have this medication of 10 years because it's very good therapy. It's a very good treatment. But another in the patient, we have Triumeg and Gemvoya. That's this medication for 1 per day we take it, and it's very well. In Romania, that's where we have like this those combinations of medication. Depends of patients on the patient, depend of disease like situation.
Any other comments?
Sometimes a patient change also combination to go to one single pill because just to reduce amount of tablets you are taking. Yeah. For example, I took for 4 years 4 combination, 4 tablet like Prevista, Norvir, and what was we are not careful. Prevista, Norvir, Epivir, and Sesentry for 4 years. Yeah. But and then after I thought, yeah, maybe is it possible that I can have one single, because I was combining with the other diabetes and heart pressure medication. But then my HIV doctor said there is one new tablet like you can try. Actually, here in Netherlands, in my hospital, I started 2019 for first trial for how you call it, this Biktarvy, you know. Yeah. But I realized also, of course, that the patient we want always to go to less, but there are also other consequences. Yeah. I realized that Biktarvy increases quick the way, gaining weight. I've gained much more weight than I did for 10 years ago. Yeah. So, yeah.
It's a very good point. Thank you very much. I'll come back to the issue about weight gain later on. I think it's important to remember, though, that just because a pill is new, it does not need necessarily it's much better than the old, and even the old-fashioned medicine. We have had the discussion, I can say, in Denmark at several occasions. At one point, a tripler was split up into 3 pills, and it was mandatory for doctors to prescribe the 3 pills taken once a day rather than just 1 pill once a day. And it turned out that it was actually a quite substantial saving on this. And we had an extensive discussion. I would say we had an extensive discussion, but in the end, it was the administration which decided. So we couldn't actually do anything but switching people to the individual pills. We made the decision at that point that if for some reason we wanted to keep some people on the medication, it should be a internal discussion within the department before doing so. So the argument was it should not be the people who had the strongest will or the best arguments who should be put on or should remain on a single tablet, but rather it should be these people who actually had an issue with taking 3 pills rather than 1 pill a day. So I think we managed to shift around 90% of all people on a tripler to the individual pills, and then identified about 10% who were in need of having who would benefit from having a single pill rather than 3 pills. And it turned out that they actually did not have any inferior biological response to this switch. And I'm mentioning and taking a little bit of time to say this because I think it's an example where economy comes into play and where the discussion is really about if we save money here, we can probably use money for other people with other diseases. And that's a quite complex discussion, and obviously that's where the NGOs come into play and need to advocate for the people living with HIV. Any comments on that? What I heard from most people, I follow about 200 people living with HIV in my clinic, and what I heard from most people were, this is not really a problem. We can easily take 3 pills rather than 1. And then there was a very few, perhaps less than 5 in my ward saying, this is a problem. We cannot do this. And for them, we accepted it. I think I made my point on that, but let's perhaps we can come back to it later on. I would like you to split up 6-8 minutes, Marina, for a brief discussion. What you have heard by now, what you learned Tuesday, what is most important for you? What do you think we should focus on when we talk about guidelines? Is it that simplicity, convenience, or is it documented effect, namely an older drug having more documentation for a good biological effect compared to newer drugs where we have less documentation, or is it the economy? So I know it's probably difficult to discuss in 6-8 minutes, but please do so, and then we'll follow up afterwards in the plenary. So now it's your time. So people are back.
Yeah, we are back.
Good. Can I hear some feedback from you?
Yeah, I said that from a point of view that economy is very important, that to look at how the price is, that everybody can get access to HIV medication if it's affordable, if you can buy, everybody can manage to pay for it. So yes, I understand that some countries they get it for free. That's not the case here in Netherlands. We have to pay very expensive insurance. So
Okay, I didn't know that.
I would object to it being so expensive because at the same time, like it's obligatory to be insured in the Netherlands for everyone, and HIV treatment is within the basic insurance. And there is this, of course, personal risk, which is a very neoliberal invention as well. And of us as people living with HIV, we pay upfront because obviously the bottle of a medication is worth more. I was bringing up, or I realized that I don't understand, or like there lies my curiosity, why as a patient I've been never offered generics by my doctor. Like why they are never part of the choice, or like at least wasn't when I was given a choice.
I don't know. Are you personally paying for medicine?
No, so the way it works in the Netherlands is that, so like you pay monthly, like let's say 100 euros, depends also what kind of things you need, because I don't know, if you need dentist, then you pay 150 a month, and there you have like around 400 euros of so-called personal risk. So the first services that you use, you are paying from your pocket. So the 400 is from your pocket, but then you go to the pharmacy and you get your medication for free. You're not paying particularly for the medication. For PrEP, you pay from your pocket, as far as I know, and it's 25 euros.
So why would you go for generics?
I meant more like that, the choice that I'm given as a patient is just, it does not include generic medication.
So I don't really see any reasons for not using generics. It's a matter of a patient, a license running out for the pharmaceutical company, which initially put a given drug on the market. And I would argue that after a given time period, and we're talking many years, we need competition. We need companies to compete with each other to lower the price. I think that's a natural part of it.
And Alejandro, you had something very relevant to say about that. In Spain, that doctors are actually incentivized to prescribe generics, and that they get a plus if they prescribe generics. And I find it an interesting idea to stimulate this in order to reduce the cost for the healthcare system.
I can certainly say in Denmark, it's just out of my hands when I prescribe medicine. The nurses and the pharmaceutical people in the hospital, they'll decide which kind of, say, Truvada to use. So they'll pick the cheapest medication. Occasionally, and that happens very rarely, but of course that will happen if you switch from one formulation of a drug to another formulation. Some people may develop allergy or intolerance to some of the other components of the pill rather than the active drug. And for these people, we will obviously switch back to the other medication. Any other comments on this? My second point, documented effect. Did you talk about that? Documented effect, I guess it goes both for virological efficacy but also for adverse events. One thing I could mention is, for example, this tenofovir TAF formulation. It seemed that drug would be better alternative to tenofovir TDF, because the expectation was that there would be a lower risk of renal toxicity, or perhaps also bone toxicity. So therefore, many people would argue we should switch all people from TDF to TAF, tenofovir. And then last year or the year before that, we had all this data emerging on weight gain, probably related to TAF. So that's an example of, just because a drug is new, it's not necessarily ideal. It's not necessarily the solution to all our problems. It's just worth keeping in mind. The other example was abacavir at some point. It's probably nearly 20 years ago when that came into play. It was a very good drug. Then at some point there was this postulated associations with cardiovascular disease, and the discussion was whether to use it for everybody. Just to say that that's where the international guidelines can be helpful. That can be some guidance, but it would obviously always need to be linked with local or national issues as well. I don't want to go into more details of this. I just wanted to point out, if any of you have access to the HIV Glasgow conference this year, there was a fantastic talk by Rochelle Walensky from Boston on cost effectiveness. She's putting up amount of euros or dollars used in relation to life years saved or quality. So that is obviously a discussion. It's not happening only in HIV medicine, it's happening in many other fields as well. If you have a new treatment for rheumatoid arthritis, which is 5 times more expensive and 50% better, is that where you should shift everybody, or should you try to prioritize it? It's really a complex discussion. Yep, you had a question?
Yeah, we have one specific for the state of Romania. All medication that we support for state government, like not we pay, the patients in Romania not we paid anything with medication for prevention to infection HIV, because that we have a guarantee. And then in the last 30 years actually, and 20 years actually, to be guaranteed to all children and all patients to infection HIV that we have medication of free, not to pay anything, not to pay to PrEP, for example, not to pay to prevention infection HIV in Romania. Just this medication, just support to Prime Minister healthcare. Yeah. That's why I am specific like this, because in the country, in Netherlands and Spain actually, they pay 100 euros for medications or for of therapy. In Romania, we not pay anything, just with free and state of government that we guarantee to take every month to medication for to the test of infection HIV. Thank you.
But that's fine and that's appreciated, but it's just worth remembering the economy is still there. It's just not out of your personal pockets. Somebody is paying the bill, so the discussion is still there. The economical part of it. Any other comments? Ilian?
I had a question actually for Bodan in Romania, because I hear often from your colleagues that they are short on medication, they are breakage, and she's been doing for 10 years, asking for donation for medication for people in Romania, and have been involved for 2 years already, trying to look for medication here in Holland for people who switch their medication, and then we give them to me the one that's still close and still valid, and then I will shift them to Romania and they will reach the patient. So my question is, how is it then possible that we have the generics. Then what is happening with your government if this still happening that people don't get medication?
Well, so also patients to be infection HIV, so new infection HIV, that we have to presentation to in the hospital, and that we try to stabilizations exactly to therapy, and the government and the hospital, we have to contact as well to be trying to a guarantee to medication of patients, because and last 29 years ago, when I have a boom here in Romania to infection HIV, also people, also children, is orphanage that this to category to patients, and then we take of prevention to infection HIV, and they'll try to take it of medication for free, not we have to pay like these medications.
I think that's fine, and I appreciate this discussion. I'm just looking at the 300 slides we need to go through within the next hour or so. So let's move on to the next item. I know Daria discussed and presented the guidelines for the general population. I think she also mentioned that there were specific issues for special groups of people living with HIV, and they are listed here, and they are part of this guideline. We're not going to go through all of them, but just let me point out one issue which is obviously of huge importance is women who either want to conceive or are already pregnant. And you would know that there was a signal 1 or 2 years ago on dolutegravir and neural tube defects in the child. And that was a signal originally coming from a cohort in Botswana, where it turned out that there was a higher risk. There was a report of several children with neural tube defect. I don't know whether you know that, but it's a serious nervous system defect. So it's an important signal. And I think the whole scientific community have been dealing with that ever since, and that has been addressed in the guidelines. It seems as if the risk, the signal is still there. It's about 2 cases of neural tube defects per 1,000 people followed for or 1,000 pregnancies, compared to about 1 case of neural tube defect in the population not receiving dolutegravir. So that's obviously a balance again, because dolutegravir is a good drug. Should many people be denied the possibility of getting dolutegravir, or how should we do it? It's especially problematic because the risk of neural tube defects seems to be associated with dolutegravir use in the weeks up to conceiving, up to conception, and the first few weeks thereafter. So it's people are. It would be easier if it was later in pregnancy, then you could just switch to other medication. But as of now, as a discussion, should all women living with HIV with childbearing potential, should they be denied access to dolutegravir? Should they be switched away from dolutegravir? And that's obviously a discussion in many countries. So the recommendations here. So just let me say that there are detailed lists here that that women who wish to conceive, listed here, what should they do? Should they remain on treatment? So essentially, if women are not on treatment, when they would like to conceive, they should be put on treatment and they should not receive dolutegravir and other integrase inhibitors. But it's coming here. You can see that's drugs not recommended in women who wish to conceive, and drugs not recommended in women who become pregnant. That's what I should have said earlier on. So dolutegravir is the one drug you should avoid for people who plan to conceive, but other drugs listed in the lower part of it are not recommended while being pregnant.
I have a quick question.
Yep.
What happened then if a woman is given a dolutegravir and then normally you come back to for checkup in 4 months or 6 months, but then between those time you fall pregnant, but you have been taking those dolutegravir already, and you fall pregnant between that period, you need to see your physician.
Yeah.
So what happened then? Because that's when then the problem of narrow tube comes to the baby, or what do they do?
But I think that it's a good point, and because I probably did not make that clear. After 8 weeks, the first 8 weeks of pregnancy, people can use, or women can use dolutegravir again. So if they come back after 4 months, my statement would be, congratulations, you're pregnant, and I'm sure it's not a major risk. But obviously that woman needs to be followed up in the ward of obstetrics, as all other women. I look at it at a community level, saying that if 1,000 women are treated with dolutegravir at time of conception, then that may lead to one extra case of neural tube defects. But for the individual woman, it's probably you can see that from what I've mentioned already, the risk is very low. So obviously what we should try to is to educate people. So if I follow a HIV or a woman with HIV in my outpatient clinic, we would obviously talk about children, and my advice would be, if you plan to become pregnant at some point, let me know so we can discuss further. If you become pregnant, let me know as well as soon as possible so that we can discuss whether we should change treatment. Yep, Leanne?
Yes, I wanted to check again. Sorry, I know you explained, but my question is, I was on a treatment, but I find out that I was pregnant after 3 months, 10 days. I had no idea I was pregnant. So imagine if I was taking dolutegravir. Luckily, I was not taking it. But would have been then affect my baby to have the neural tube defect?
But that's the point. For the individual woman and for the individual child, the risk is very low. So at that point, you would argue, I don't think that should lead to any other medical interventions. I mean, at that point, you would just follow. And we have the discussion in a country like Ukraine. The argument has been put forward: is it better to treat all women so that they actually have the benefit of dolutegravir, knowing that there may be a risk for a severe birth defect for 1 out of 1,000 women receiving that treatment? And that's obviously, it's a discussion. Some I've discussed with many women about this, and some will say it's an extra risk of 1 out of 1,000. I don't have any problem with that. I'll run that risk. Other women will say, I don't want to run any risk identified at all, and they will ask to change medication. But the point is, and what's difficult here is that the change, the switch of medication should be done before you conceive. If you come months later telling you're pregnant, there's really not much you can do at that point, rather than just following up knowingly that the risk is 1 out of 1,000. It's a very low risk. Is that okay? Any other comments to this? You will notice that in this table there's a lot of insufficient data about safety and efficacy, and that's general for all kind of medicine, that there's very often this label that we don't have much data. Some of you will remember that efavirenz was actually listed for a long while as being associated with disorders in the nervous system, and only after 20 years or so it turned out that there was not this effect at all. So it's also a matter of, it's a balance between potential severe toxicity and efficacy of a given drug. Yeah.
I wanted to check why actually you don't have so much data on this, because it has been happening for years and years, and we have a lot of advanced with the researchers. Why they cannot find any data?
It's first of all, it's a good question for some of them. If you look at bictegravir or darunavir or cobicistat, it's obviously because they were introduced recently. For raltegravir, there is some data on raltegravir. So I think that's what I can say right now. I really don't want to say more about that. Is that okay?
No, it's okay. No. I don't have anything to say more, so it's...
No. So and then it's just going through it again, saying that if you are after 8 weeks of pregnancy, you can use dolutegravir safely, and these are the recommendations for that situation. Now, other drugs, I think it was mentioned in the previous slide. If you look at the lower part of that slide, it's saying that several drugs actually have lower concentrations during second and third trimester of the pregnancy, so therefore they should not be used. That goes for the cobicistat boosted regimens. Good. So that's what I want to say about pregnancy. There's a long and a complex discussion of when should you start ART in people who have an opportunistic infection. So these are patients with a low CD4 cell count. They are in need of treatment, ART, but they also have an opportunistic infection. The general message is that all these patients should be treated as early as possible and not later than 2 weeks after starting treatment for the opportunistic infection. That's the general recommendation. Then there are a few exceptions, primarily TB and cryptococcal meningitis, where the concern is, especially for cryptococcal meningitis, could there be a risk of iris immune reconstitution if you start treatment early? That could lead to increased inflammation within your head, leading to deterioration of the disease. So therefore, the recommendation for cryptococcal meningitis is to postpone ART for at least 4 weeks. That's very well documented in randomized trials, and the same goes for tuberculosis, where you will also, at higher CD4 cell count, delay initiation of ART for some weeks. It's a medical issue, I would say. More to the general point, the take-home message is that in general, most people should start ART as soon as possible. That's one of the issues which have actually been dealt with, addressed in randomized trials, and we know we have solid evidence that this is right. The reason I spent some time on this is that I know for other situations, other places where I've discussed this, that some people tend to delay ART. So the take-home message for you is to use or to advocate for early treatment.
I have a question, quick one.
Yeah.
Why in low-income countries they put immediately patients on a TB tablet, even if you don't have a TB?
That's a discussion whether they could have a latent infection of TB, and the concern is that this latent infection could lead to active disease, and therefore you want to treat with a preventive treatment. It's commonly used in Africa and many places in Eastern Europe. We don't use it that much in Western Europe, but the discussion is obviously whether we should do or not.
Yeah, because I was, for example, I was on a TB for years until before I come in Europe. I was on TB medication. When I get in Amsterdam, they asked me, "Did you have a tuberculosis?" I said, "No." So you have been taking a TB medication without having a TB. And I was very, very in shock because the doctors, they don't communicate and explain to you what are your treatment. They just treat you like you don't know anything. They just give you pill. Yeah.
There is actually a point in this because it has been well documented that in many places in Africa, I can remember studies from South Africa and Botswana, it has been documented that taking this isoniazid treatment for latent TB, it's associated with a better effect, a better outcome, a better survival. So it's actually, I think it's the right to do in that situation, but obviously you should have been informed that this was what you were being put on.
No, but even if you are not living in the rural area, because that's where mostly is very dangerous with more people, but you are living just in a suburb, but you still go on a TB medication. Anyway, I was in South Africa anyway. That's the reason. Thanks.
Good. So just, and I'm concerned this is getting too technical that we discuss all different kinds of treatment. So let me just say that the guidelines also include recommendations for which kind of treatment, HIV treatment, you should receive while you're on TB medication. But let's skip that and move on to another issue. The guidelines namely include recommendations for people who have impaired hepatic function and impaired renal function in the dosage and the drugs to avoid in a given situations. Another issue I would just briefly mention is that there may be an overlap between comorbidity and potential adverse events to specific drugs. So if a drug is associated, let's say, for example, tenofovir, TDF, that's associated with renal toxicity. So that would not be a drug of choice in people who already have chronic kidney disease. The same goes for cardiovascular disease, where probably drugs like abacavir and some protease inhibitors should be avoided. But that's one thing. The other thing is probably, what about people living with HIV having or receiving other medication? And that's actually an issue which has been ongoing for years because medication often interact with other medication. So there's this drug interaction website from University of Liverpool, which is actually very helpful So whenever people call me asking whether there's an issue between a given HIV drug and other medication, I go to this site and I see here whether I check whether there are any important drug interactions. And I've entered an example here between dolutegravir and metformin, and they say there's a potential interaction leading to a higher level of metformin. And that's obviously not only for the HIV doctor to know, but also for the doctor putting a given person on metformin for diabetes. And that's where we need the interaction with other specialties and general practitioners. My usual recommendation to people living with HIV is that if they start up new medication, always ask, could there be an issue with the HIV medication and interaction? And I often recommend them to ask the other doctor to call me if they're in doubt. It's difficult for GPs to be aware of all kinds of interactions, but people who deal with HIV patients should know. There is often a concern about interactions, but it actually turns out there are very few significant interactions with a clinical implication. So that's probably the important part to know. Yeah, it's summarized in this. So the problem in drug interaction is that if you get a higher concentration of a drug because your HIV medication affect the metabolism, then there's also a higher risk of toxicity. And if you have a lower concentration of a drug, that will lead to a higher risk of insufficient effect of a given drug. So that's important just to know. And I was attending this HIV Glasgow conference this week. It's actually a very good conference, giving a very nice overview, and it's highly recommended. But they were making this point, these people discussing drug interaction, saying that it's getting less of a problem today, but it may be that it's more a question of the HIV drug efficacy now rather than the efficacy of other medication. So it is actually an issue coming into play for the efficacy of the HIV medication. It's just something to be aware of without going into many details about the specific drug interactions. Nobody will know all the interactions. We'll have to check, and that's where this HIVdruginteraction.org is very helpful. Comments to this? Friday afternoon, 1 o'clock. The guidelines also include a long table of people with swallowing difficulties, what can be done there. And that's actually also helpful, knowing to which tablets you can cross and which capsules you can open. So that is good. So it is actually possible to construct a potent HIV regimen. Obviously, in the future, swallowing difficulties, that will be a place for where you can use the injectable drugs. It's not in the guidelines as it is now, but it will come into play in the coming years. I'm sure about that. Just one or two words about PrEP, pre-exposure prophylaxis. I would actually like to know whether it's used in your countries. Can I have some feedback on that?
In Netherlands, the PrEP is used. I highly recommend it for men who have sex with men. You hardly hear anything with the women, or the campaign is more putting on front the gay men. Yeah, men who have sex with men, of course, with the trans, but but it's known that PrEP exists in our country and is being used. But you buy it also for yourself, as Simon said. Thanks.
So in Poland, it needs to be prescribed by the physician, but it's only available. So the patient has to pay. It's not reimbursed by the National Health Fund.
Is that expensive in Poland?
I don't know by heart. I don't remember. I can quickly check.
Yeah, but that's right.
It was around 30 euro as well. So it's just a bit more than the Netherlands. But the thing in Poland was that PrEP is available via private clinics and not via public services.
Yeah. Is that the way to do it, do you think?
In Romania, the PrEP, it's not very graduation like that, because gay men they accepting for PrEP in Romania is function actually 1 year, this PrEP, and now we stop it to PrEP in Romania. It's not to continue this program to PrEP. Just we action 1 year in Romania, actually in 2016, 2017. It's accepting for PrEP, but now it's a stop now, this program. My colleague in organization to Arad Bucharest, they try to continue in organization to this PrEP, but in a hospital is not continuing this program PrEP.
Okay. Any other input?
From Ireland, PrEP was made free since November of last year. So that was the first phase of rolling out PrEP to men that have sex with men or gay men. And also the second phase was supposed to start in April of this year, but because of COVID, they've actually shelved it off. But the second phase was to go to people of minority and sex workers, and I think it was minority and sex workers or vulnerable people. So PrEP is free at the moment here in Ireland. Thanks.
That's also the situation in Denmark. It's being prescribed by doctors in hospitals, in very few hospitals in Denmark. It's free of charge. People are coming here every 3 months. So far, it's only men having sex with men. Where we find the indication, there's a rule saying that they should have had at least condomless sex twice within the last 3 months, or having had a sexually transmitted disease, or having received post-exposure prophylaxis to be allowed to be given PrEP. But I mean, people know each other, so they know when they come to hospital, they should say that they have had condomless sex within 3 times within the last 3 months, and then everybody is happy and it's prescribed. So I think it's fine if people would like to have it also after having been informed about possible side effects, etc. I think obviously it should be prescribed to at least men having sex with men, but I think it's good to see that in the EATG guidelines, it actually also say that it may be considered in HIV negative heterosexual women and men who are inconsistent in their use of condoms or have multiple sexual partners, where some of them are likely to have HIV infection. We're still not there in Denmark. I could imagine, and that's what I heard from you as well, that it's not the case in many other countries in Europe.
In Greece, as far as I know, well, actually in UK where I used to live, it is free. There was a trial. You have a doctor, they prescribe you the medicines, and it's easy. Sometimes, I mean, I had to wait for 6 months to get in the trial. There is a waiting list, but the sexual health services, from my experience, are amazing. They also call you back every 6 months to have your tests and check your liver function, and it is very good. But in Greece, the situation, of course, is not the same. As far as I know, there was a program some years ago where people could get for free, but it was very limited for very limited people. As far as I know, they started, like one doctor in a public hospital started again having a fund or a program, but again for very limited people. That it stopped during COVID times, and I'm not sure if it's coming back, but most of people have to pay or buy PrEP from abroad. And of course, it's more complicated because no one is really checking how their liver reacts, or
Yeah. It's more complicated and more unsafe. So both developing side effects, but also if for some reason they acquire an HIV infection while being on PrEP, that obviously also lead to resistance. So it's important to follow people. I fully agree.
Yeah.
But I guess PrEP it has been relatively quickly implemented in Europe. Denmark was one of the last countries to come into using it, but not one of the last, but we're certainly not in the first wave of we're not among the front runners, I would say. Then moving on to follow-up guidelines. I have a lot of different tables, and you can, even if you have the...
Can I have a quick question?
Yeah.
Why did it happen in Denmark like that, in a developed country? That you were in this last wave? What was the reason for that?
Now it's getting outside the scope of the international guidelines, but the reasoning in Denmark was that, and I'm not proud of saying that, you can probably see that, but the argument was that PrEP is not really needed because there's a good alternative. So why should the Danish society pay for PrEP when there's a good alternative in terms of using a condom? And that was a discussion going on for more than a year before the arguments were made that it is actually also for the society an advantage to reduce the number of newly infected people. And at that point, it was tolerated and rolled out.
Can I add something else?
Yeah.
Sorry,
Yeah.
I'm sorry if you're finished. I just think it's very, very important to have sexual health clinics, and I can see the difference, like how more complicated it is in Greece to like go to the hospital, ask for PrEP, because you don't get this information that easily. I mean, even if a program is on, you don't really know if it's on. While I can see the difference with England, where you have the sexual health clinics that they advertise PrEP. It is there, you go specifically there, like you call them, they know what they do and they know their job. And how more complicated it is in other countries that these specialized public sexual health clinics do not exist. And for example, here, most people go for HIV test at the checkpoints, and they do double work than the public hospitals. Because it's like you have to book an appointment, and like there's so much bureaucracy just to get tested. And unfortunately,
I think that's very nicely phrased. Thank you very much for that. I think it's important to move PrEP to where people are. Certainly, I mean, and so many of these people they're not familiar with hospitals, and they do not want to go to hospitals. So if you, and that's, the guidelines are here, and there's room obviously to establish clinics in the cities or in the greater cities. And what you have seen, obviously, from London, it's exciting, I think, and that there's more or less a self-service for testing for STIs and for HIV, etc. So I think there's definitely room for improvement in many countries, making it more friendly to people who are in need of it.
For example, in Greece, you have to to find an appointment to a public hospital. Then you have to meet the doctor at whatever date the appointment is. Then they have to prescribe you the exams, and then you have to find an appointment to get the exams done. So it's like it can take so much time. Yeah.
Good. So just moving on to how people are followed up, because that's also a part of international practice. The guidelines, the EATG guidelines, they include long tables on follow-up, and you can see them here. So they are extensive, and I think many countries do not really use all of it, but it's in many countries it's referred to that this is the standard of care in the EATG guidelines. Should we do more? Should we do less? And obviously some issues will be more important in some countries than in other countries. You can see that each visits, the question is, how often should they be done? And I think we have, over the last 5-10 years, moved from follow-up visits every 3 months with a full blood evaluation to follow-up every 6 or 12 months. In my clinic, I'll see patients most of them were stable. I see them every 12 months. They'll go for blood tests twice a year, and I'll check up on the blood test, and if there's anything, I'll call them in. So the idea is to move from a follow-up, standard follow-up every 3 months, to a more targeted follow-up to the people who are actually in need of being followed closer.
I have a quick question here, psychosocial.
Yeah.
What do they mean by this follow-up guideline? What do they mean by like partner and the children of employment? What do they mean on here?
Where are you now? I'm sorry. Partner and children. So the point on partner and children, it's essentially following up or doing it at baseline when people come in, being diagnosed with HIV, just testing children and the partner, and obviously if there may be good reason for testing a partner, right? Again, consecutively, especially if the index person is not well treated, so that partner is actually at risk of having a sexually transmitted HIV. So that's why I think it's fair that it's not being put in as every 6 months you should do an HIV test. That would not make sense, especially as we know now that if you are well suppressed, you don't transmit. So it would not be the right signal to either the patient or the partner to make testing every 6 months.
And my question also is like, for example, there are here in Netherlands, women who are pregnant, is mandatory to do HIV test immediately. You are tested, so then you can go on treatment to provide mother to child transmission.
No.
But it's not mandatory that immediately you have to tell your husband has to go to do HIV test. It's more, why is it that? So men, they don't have any excuse to make them to go to do HIV test.
Yeah.
But the women, well, if they are pregnant.
Yeah. But I can certainly see that point, and there have been discussions in many countries whether pregnancy should actually lead to both men and women being tested. That's not how it is now. You can argue that it should be so, but the other point is obviously that it's not mandatory for the woman who is diagnosed with HIV to tell her husband. It's not mandatory in many countries. It's not illegal not to tell. And that's obviously, as a clinician, something we struggle with from time to time in the clinic. And it's a matter of respecting the individual person. But you could obviously argue, why not protect the other person as well? But that's a long philosophical discussion, a political discussion. I can just say it's certainly not in these guidelines as it is now. So these tables list what you should do every year for CD4 and viral load. It's every 3 to 6 months. With the CD4 saying it can actually be tested just once a year if perfectly stable on ART and at a higher level of CD4. I think that makes sense. I think it's important to reduce the number of tests being done. We have, over the many years I've been involved, we have tested and tested and tested. And the problem in testing is obviously that some results will lead to further examination and often useless examination. So therefore, there's a point in reducing it to a level where it's actually acceptable and reasonable. Any comments on that? It's a very medical comment, I guess. I sometimes hear from people with HIV that they would like to have a CD4 cell count every time they have blood drawn. But I'm trying to explain what I just explained to them, and most people accept it when they hear the reasoning behind. In Denmark, we test for hepatitis once a year. We do so for syphilis as well. Some people will object and say, well, we don't have any risk of these diseases. Why are you testing us? And I'm trying to make the point that obviously having it as a part of a program can actually, from time to time, diagnose some people we would otherwise not have diagnosed with the disease. But it's a screening, and it should not be done too often. One of the places where it's not commonly used in all countries is testing for tuberculosis. There are in some countries, Spain, Italy, Poland, other countries in Eastern Europe, Central Eastern Europe, high prevalences of TB, and therefore obviously the follow-up needs to focus more on TB in these regions than in others. Influenza flu vaccination, the recommendation is an annual follow-up on that. There's actually an entire section of vaccination in the EATG guidelines. So just to say, there's this comprehensive program for all kinds of measures. You can see cardiovascular risk assessment once a year or twice every second year. Also evaluation for liver function. There was one thing I want to mention. It's here on bone disease. That's one of these which have actually changed over the years. Just a few years ago, there was a very strong recommendation on doing DEXA scan for every people very frequently. Now it's moderated, so it's a follow-up frequency of 2 years. Assessing in a computer program, doing a risk assessment, and then doing DEXA scan in special patient populations. So just to say, or making the point that this is the screenshot as of October 2020. If you looked in the guidelines 2 years ago, they would look different. If you look 2 years from now, I'm sure they will also look quite different. And right now, I think there are more things being added, but there are certainly also things that are recommended less frequently now than 5 or 10 years ago. And I think that's good. Comments to that, it's a long list of details, because then I would like to just briefly talk a little bit about changing medication. So if you look at what are the reasons for changing medicine, these are a long list of reasons. What is actually important is that biological failure, it's not a common reason for changing medicine. That's what we were concerned about. That's what we feared 20 years ago, that many of these people taking medicine every day would develop resistance. It's not happening. It's very uncommon. In my clinic, it'll happen once or twice a year, but very infrequent. What is frequent is that people come up with questions to the medicine, having a concern about medicine or having symptoms, and then we will discuss and change medication. Toxicity is one thing. Concern of long-term toxicity, weight gain is obviously another one. That's what I would really like to talk about in the last 20 minutes or so. So economy is also, we mentioned that already, talking about initial treatment. It's obviously likely to be an issue during follow-up as well. So let's not dwell on that, but just moving on to one issue is that we have had triple therapy for 20 years or more. Now there's a move towards dual therapy. There are several possibilities. It's probably more likely to be used for biologically suppressed people, so that it's a switch of treatment, but it's also in the guidelines now as a recommendation for initial treatment for treatment-naive patients. I think this is actually exciting news, that treating with, for example, dolutegravir plus lamivudine or 3TC, it can be administered as a combination pill once a day. Part of the toxicity which we saw for the nucleoside backbone, it's eliminated. So that has an interesting perspective in itself. Are there comments to this? Do you use dual therapy in your countries? That's a little bit of nodding. Nobody is saying anything right now.
Yeah, I was saying something.
Yeah,
yes, we do. We do use dual therapy in Netherlands. So yeah.
I think it's good. It's in the guidelines now. I think it's important, and I think it has to be used in a careful manner. Bogdan, did you have a comment?
Yeah, in Romania we have the same like this. Yeah, in the Bucharest probably. I'm not sure exactly on the far in Bucharest, but in the Bucharest is happening like this. Yes.
Yeah. I think it's, obviously it's important to know whether there is any kind of HIV resistance in the background, so before you just change. But this is certainly a possibility, and I'm sure that will go more into play. I was attending, I have already mentioned that, this HIV Glasgow conference this week, and I think there were a lot of exciting news on new treatment and new ways of using treatment, and dual therapy with injectables. It's coming in the good.
Yeah, we have one suggestion. I think though this talking in the last years in the conference in Bucharest, the doctors Adrian Săreinu Cercel, the manager of the hospital to Matei Balș, they were asking like this situation. Probably it's the new medication for injection actually. for one injection on, you are coming on the hospital the next for 6 weeks, 6 months actually. It's most very interesting like that, because a patient without taking medications, we have a 1 injections for next 6 months. This is quite very interesting like that.
Yeah, but that is interesting, and certainly for a group of people who have difficulties in taking daily medicine. As it is now, injectables are for use every 4 weeks. It may be up to every 8 weeks. And I think if it is really to come into play and to be a nice alternative, I think it should be every 3, 4, 6 months. But we are not there yet. That will certainly be for the.
This is a nice revolution in Romania, because in Romania they have a big revolution like that. If you take 1 injection for 5 weeks, this is a very nice. The doctor Adrian Străinu Cercel, they asking like that. You have possibility next of 5 years and 10 years. I'm not sure exactly to introduce in Romania like this therapy. This is a new revolution for a new possibility.
It is, but it's not solving all our problems. The people who have difficulties in taking daily medicine, they are likely also to have problems with meeting up every 4 weeks. And the problem is that if you inject medicine, it'll stay in your body for quite a while. So it'll have a long tail of lower concentration. And therefore, at that point, you are at risk of developing resistance. So you change your problem for once daily to a problem every month, and if you don't meet up every month, then there's a problem as well.
Depend of Dr. Adriano Străinu Cercel, they asking depend of a patient like this administration medication. Not only patient we have to benefit like that. For example, introduce myself. I'm first time to be infection HIV, and 27 years ago when I have a baby born like that, they we introduce in first to therapy in 1996. We have to first time to medication to prevention to infection HIV, and in 2020 when I have a 12 drops, 12 of drug medication per day, because we have 3 in the morning and 6 in the morning and 6 in the evening.
Yeah, but I can see that. But what I'm saying is it's a good alternative for some people. It's not going to be universal for everybody. If people have a lot of resistance in their background, it will certainly be more difficult. Let me just move on so that we manage to talk a little bit about weight gain before we end. Toxicity, long-term toxicity. Long-term toxicity is obviously something you will not get to know about before you have used the medicine for a while, often for many years. It happened for Cidovudin and other of that kind of drugs. Stavudin, diagnostics, lipodystrophy, that's all dealt with. Cardiovascular disease and Abacavir or some protease inhibitors, it's still an issue, and it's being dealt with, and it's already in the guidelines. Same goes for tenofovir TDF. The more recent one is TAF, tenofovir TAF, and integrase inhibitors. That has been the hot topic. It's now in the guidelines for dolutegravir and TAF, and there's a concern for other integrase inhibitors as well. But these are the results behind it. This is from this Glasgow conference. Andrew Carr from Australia presented this, and these are his slides. So you can see, if you look at the left-hand side, there's over time there's a rapid increase in weight for most people, regardless of which kind of HIV medicine they're on. The blue color is integrase inhibitors, such as dolutegravir. So that's associated with a high increase in weight, whereas non-nucleosides, such as efavirenz, is associated with a lower weight gain. What you can also see from that figure is that most of the weight gain is in the first year of treatment, whereas afterwards it's a slower increase. And at the conference, the point was made that probably in the first year, there's a high increase because people were sick and therefore moved back to a healthy status. And this is in a US population. And what you see from year 1 onwards is probably what you would expect to see from most adult people in America, mainly gaining 1 or 2 kilograms per year of adult life. So that's interesting. And the other one I just want to show is this is switching from tenofovir TDF to tenofovir TAF, and you can see an increase over time. Just ending up with showing this, that this is for men and women, and you can see that the weight gain is more pronounced for drug combinations, including TAF and dolutegravir. That's the red line for both men and women. And you can see that regimen in the green, tenofovir TDF plus efavirenz, it's the lowest increase over time. What you can also see is that the weight gain for women in this advanced study is up to 10, 12 kilograms, whereas for men it's 7 kilograms over 144 weeks. That is nearly 3 years. So it is a substantial weight increase, and therefore it's in the guidelines as of now. That's something we identified 2 years ago, and it's quickly moved into the guidelines. And that's another place where I think you can argue that international guidelines are actually of great value, because it's very quickly provide you with a tool for what to focus on in your daily practice. Any comments on this, on weight gain? I can imagine it's something that people are talking about.
I just want to ask, is it because of the drugs themselves? Like, is it how the drugs interact in the body, or like with cholesterol or whatever it could be? Or is it has to do with patients' mental health?
It's an excellent question. It's still open for discussion as it is now. It's relevant, I think, to notice that there are actually some drugs which is associated with a higher level of weight gain than other drugs. But it's also a matter of people having a chronic infection, being put on treatment, and therefore returning to a normal situation, and therefore gaining weight. I've seen figures showing that it may be a weight gain, but it's also returning to the normal weight to be expected in a given country or in a given cultural area. So I think weight for many of us a problematic area you can discuss and address in many different ways. I would probably be a little bit careful of associating all weight gains with drugs being used for HIV infection. It's a multifactorial, and there are many other factors to be considered, including diet and exercise.
Hi, can I say something?
Yeah.
Weight gain for example, people with the comorbidities, and it could also be more dangerous. So what would be then suggest to a patient if is taking this switch and then medication is helping her more to gain more weight, even if she tried to do sport but still gain more? to go back to old medication or to try something new?
I think it's a complicated question, because I mean, if it's obvious that just after being put on or switching to a given regimen that you gain weight, then I would obviously explore other issues. Have you exercised less than before? Have you been on another diet? It has been obvious for many people, if they switch from tenofovir TDF, you certainly had a lot more appetite on tenofovir TAF. So that may be that you had nausea or low level of nausea and no wish to eat while on tenofovir TDF, but actually gained that appetite again while being on tenofovir TAF. So there's, I think I would be careful of not just switching around treatment frequently for this matter. I would explore whether there are other issues. One of the things I've seen here in Denmark in spring 2020 is that many of my patients, people living with HIV, they gained weight during springtime because for the COVID situation, they stayed at home. They did not go to fitness. The only joy they had left was to eat more or better, so they gained weight. And that's, I know it's talking around it, but there are many other good reasons for weight gain, and I think it should not just be focused on medicine, but obviously be kept as one component of the entire situation. It may be that we know a lot more in a year's time, so we can meet again. It's getting close to the hour. I planned a few more split up sessions, but I don't think we should do that. I can just ask you here in plenary, all these international guidelines, can you think of ways to evaluate results for a given clinic? And can you compare with the international standard? Do any of you know ways of doing that, evaluating a clinic's result or a national result on HIV care? What I'm thinking of is actually 90-90-90 goals. So 90, you have heard about the 90-90 goals, haven't you? Yeah, and then it's by 2030, it's getting 95, 95, 95. So what we can look at in a given clinic is obviously how many people are on ART and how many are fully suppressed. And that's what I would like to end with, just showing you. And it's not a good slide, but this is from 2015. At the x-axis, at the very bottom, you can see the percentage of being on ART. 90% or more were on ART in very few countries, and 90% of them were fully suppressed in here. So ideally, all countries should be in this region, above 90 for both of them, and none of them should be in this region. So what you can see is that there are countries in Northern Europe and also Southern Europe in this area. So that's a way of illustrating where you are compared with other countries, and that's a way of seeing whether you are dealing with the international standards. That's obviously, and then when I've said that, I've obviously not talked about the first 90, namely to diagnose at least 90% of the people who live with HIV, provide with a HIV diagnosis for these people. And that's obviously at least as important as this. So that is the last slide. The question for you: are international guidelines helpful for your work? And is there anything you would like to have included in the guidelines if you should decide?
Yes, that's what we're helping with me. I will asking my colleague in other organization to aspect like this infection HIV, and that was a good presentation for all materials, also presentation as well. And I will try to implementation with my my organization and try to be asking to another doctors in on a village in Bucharest.
Yeah.
Thank you.
Any other comments at this stage?
Definitely, this international guideline it's helpful. And I'm sure here in Netherlands they must be updated now that also there is a new version. But I will check. They're always communicating in Dutch, but I will check if that also it's available. And yeah, I don't think I can. There is anything I can include now for this guideline.
No, I just wanted to say that I think what I'll do is I'll go back to our national guidelines and just double check or just check to see what the national guidelines have comparing to what the international guidelines have.
Yeah.
Maybe we could have some loopholes in the national guidelines that we need to maybe adapt from the international guidelines. Thanks.
Thank you. Just keep in mind that these EATG guidelines were just released very recently, so it may take some time before they're translated into national guidelines. I think it's good to see, for example, for PrEP, that there's actually a saying for not just men having sex with men, but also for other population groups. So I find that helpful.
Yes, we did have a session on the PrEP in Europe. So I did address also that question about to try to change the campaign, make it positively like PrEP is a public health for everybody. So to give it another face, because there is a lot of stigma into using PrEP. Even people who are using PrEP, they sometimes have to hide because they are confused that they have HIV. So there is always this stigma with the HIV related with the PrEP that they people who use them also they don't feel freely like. So then I said like it's better we change and give it another image.
Yeah.
So.
But that's a good point. Thank you.
I will try to implementation this program to the PrEP to new introduce of in Prime Minister Healthcare. I would like to good campaign to continue for this program to PrEP because I last year's to meeting in the Russia to about to PrEP European, and I would like to this again introduce in Romania to the PrEP because it would be very necessary because I have here in Romania to community LGBT, and I will try to protect it, and I'll try to prevention to infection HIV, and I hope to all my colleague in organization to be tried to introduce again in program to Prime Minister's Healthcare, and that was good program to healthcare and good program to campaign to PrEP in Romania.
Very good, thank you. Any other comments? If not, I would say thank you very much for your active participation. I think I've enjoyed these 2 hours. I think it has been good. And we have had good discussions. I hope I have not overwhelmed you with details. It's certainly not like meeting up physically, but I think it has been a good session. So thank you very much. I don't know whether you have anything to add, Marina, at this point.
No, I just wanted to thank you. I think the session was very, very interesting. And thank you everyone for joining and for your participation. And I wish you all a very nice weekend.
Same to you.
Thank you so much.
Goodbye.
Bye bye. Thank you everyone. Bye.
Bye.